Thank you very much, Ayaz. That was fantastic, the case, and just perfect segue for our keynote speaker. It's my distinct honor and privilege to introduce Mariell Jessup, who is very well known in heart failure circles. Ms. Jessup is the Chief Science and Medical Officer at the American Heart Association and Emeritus Professor of Medicine at the University of Pennsylvania School of Medicine. She was the Chief of Scientific Officer of the Leduc Foundation from January 2017 through 2018, before moving to the American Heart Association. She practiced heart failure and transplant cardiology for 30 years at the Hospital of University of Pennsylvania, where she served in a variety of administrative roles, including Medical Chief of the Heart and Vascular Program and the Clinical Chief of Cardiology. She has been a longtime volunteer of the American Heart Association and was a member of the Board of Directors of the National Heart Association and the president from 2013 to 2014. So I'll invite Dr. Jessup for our keynote address. Please get a warm welcome to her. Thank you. Thank you,
Dr. Carr.
This is a little token from us, and thank you so much.
Here, let's put this here.
I'll take it.
Well, Dr. Carr, thank you so much for that very kind introduction. I'm so pleased and honored to be here with you today, and I want to echo Dr. Kiernan's call out to the program committee, who has just done such an outstanding job on all of the discussions and speakers. But I also want to have a call out to all of you. You have given up the precious weekend because you wanted to get smarter, you wanted to become better clinicians, and you wanted to do that for your patients. And I think you should give yourself a big hand. So my charge is to talk about charting the course of cardiogenic shock, and in fact, that's what we've been doing for the last couple days. I do want to just call to my disclosure. I don't have any relationships with industry, but I am employed now by the American Heart Association. Having said that, the opinions you're going to hear and my statements are my own and not representative of the American Heart Association. So we've been a big reflective mode at the American Heart because we turn 100 this year. And so there's lots of things that we're doing to sort of celebrate that. Now, many of you may have seen this picture about the 5 founders of the American Heart Association, and I'll tell you that inside a little bit like it's always the old white guys. But I learned something last year. There was a social worker named Mary Hadley, and she said to Paul Dudley White, you've all heard of him, you know, there's all these people that have had a heart attack, mostly men at that time, and we don't know what to tell them to do. We're not letting them go back to work, but what should we do with them? And these scientists, these clinicians that began the American Heart Association said, you know, we don't know. We don't know what to do. We better get more science. And that's how the American Heart Association started, because a woman said, we got to do this. Yes. So that was 100 years ago. 25 years ago, a quarter of a century ago, we had this randomized trial in cardiogenic shock. And I heard somebody say yesterday it was a negative trial. I also want to point out that it was led by a woman. So maybe what we're doing wrong in cardiogenic shock is we need more trials run by women, but I'll stop my diatribe about women in a minute. But what I want to point out is in this table from the trial, yes, the 30-day mortality was not significant, although there was a trend for people over 75. At 6 months, there was a difference. So it begins to make you think, well, maybe our endpoints are not exactly right. However, where we are today, as has been said over and over again, is if you look at the evidence base for both the American guidelines and the European guidelines, it's just non-existent. Everything is consensus opinion or level C. And what's even worse is, if you look carefully at the guidelines between the Europeans and Americans, they're not even in agreement. So that's bad too, because I think we're still treating the same patients. So it reminds me of the story, if you're doing something the same way you've been doing it for 10 years, the chances are you're doing it wrong. A lot has changed in 10 years, so maybe we're doing something wrong. And the corollary to that is, insanity is defined as doing the same thing over and over again, expecting different results. You know, you've all heard that. So I think we do have to say, maybe we've got to start over and think about what we're doing in a new way. Now, as part of our process at the American Heart, we've gone through a deep series of reflections and examinations and sort of strategic planning, and we decided that there were 6 key trends that are going to face us in the next 20 to 30 years as an organization. And I don't have time to talk about all of them, but they are the aging of our populations, and this is not just in the United States, probably not even in Canada, technology-driven healthcare, the blurring lines between companies and nonprofits, wealth inequality, unconventional work environments like telehealth, and environmental impacts on health. Now, you may say, really? I mean, the environment and cardiogenic shock? I will tell you that we, several months ago, met with the CEO of JCO, you know, the Joint Commission. His #1 priority is looking at the impact of healthcare on the environment. I have to say, I was surprised at that, but you know, all the packaging, all the disposables, everything we do, and we do a lot of that in cardiogenic shock, he thinks that's wrong and that we need to be attuned to that. So the environment is going to impact everything. So let's just briefly talk about the aging of our population. On the left-hand side, this was a chart that I had ChatGPT done. One of my personal efforts has been to really embrace what AI can do for me as a person. And mostly it makes up stuff, in case you haven't played with it a lot. So you really have to be very discerning. But nevertheless, it shows you in the lighter green, the population in 1950, and in the darker green, the population now. And what you see and it's hard to read, I know, on the far right of that is the people in our country that are over 65. So the birth rate is going down, and the older people are living longer, which is a good thing. The real vanguard of this trend is in Japan, which is on the right-hand side. And again, that was 1940, if I remember correctly. You can see that most of the people are young. And on the bottom of that is in just 2040. And the vast majority of people are over 65. Well, what does that have to do with cardiogenic shock? Well, guess who gets cardiogenic shock? Old people. So we're going to see much more of it. And guess what else? All of you who are young, you're going to be old then. And there aren't going to be as many people coming into medicine because there aren't that many people being born. And medicine is not attractive to many people anymore. And so this is going to be a real challenge for this field in particular. I've listened to all of you. You're coming into the cath lab on Sunday and doing all these things. People don't want to do that anymore. And so taking care of cardiogenic shock in the future is challenging for so many reasons, but the birth rate is a problem too. We've talked a lot about technology during this, and this is just PubMed searches for AI programs. And it's, you know that, there's just a gazillion articles and there's a gazillion new journals publishing all of this. But it's all for the point of precision medicine. I mean, why do we care about AI? Because we're going to get the right therapy for the right person at the right time. But this is a beautiful slide made by my friends Joe Lascalzo and Elliot Antman. And if you look, it's hard without a pointer, but if you look on the left-hand side, the idea is that we recruit from a whole bunch of people, and then you go clockwise, and we collect data from them, and then we use that to describe individual patients. So that's sort of our phenotype, and then we collate that, and then we analyze it, and then we report it, and it's a virtuous circle. If you look on the right, however, there's in the future, which is supposed to be now, there's all kinds of things we're getting. We're getting things from our Fitbits, and we're getting things from our the way we eat, and we're getting things from the environment, and we're getting things from all kinds of labs, and all of that is going in, and then that's supposed to really deep phenotype our patients. And that's the theory that will happen, is that by taking the EHRs and taking the data, we're going to be smarter, and we're going to really describe patients. The problem is we're not doing that well, because we still, if we look at what's being published right now, it's the same old, you know, that these were how many people that were men, how many people were women. We're not even describing race and ethnicity very well. And if you look at that picture on the top of the left-hand side, we're supposed to be recruiting people that are diverse, but we all know we're not doing a good job of that in this country, and we're a diverse country, so you can just imagine what's going on in other countries. And so that's a big problem. But a bigger problem is this as we go ahead, and that is, if you look down in the box, that's the kind of clinical phenotypic data we collect now. We think we're really thorough. We get an echo, and we get an EKG, and maybe we get a nuclear study, and now there were some new things we talked about. But we're missing millions of other data points, including about the environment and genetics and transcriptomes and connectomes, and then the relationships and the proteins, all of those things. And that's probably what we need to really be precise. And cardiology, the cardiovascular field is really behind on doing this. Our friends in oncology, they're doing a much, much better job. We just cling to the things we know how to do. And we're just not somehow spreading our wings and getting our wings around this kind of data. And then we forget that AI learns from humans. So this picture is taken in India, where all these women are lined up in a row, and they're marking colonoscopy so that AI knows how to detect abnormal colonoscopy lesions. So I don't know if these women know what they're looking at. And I'm sure they're well-meaning, but that's how the AI of reading colonoscopies is being derived. So we have to think about it as good as the data. And so this is my favorite study, even though it's somewhat old, in 2016, and that was everybody thought we were really clever and we knew all the variants in HCM because we'd done all these really good studies, and then they went out and said, oh, well, maybe we should just check this out in people of color, and they found out that those variants were really, really common in what we call African Americans in this country. And it's because they had derived their data from primarily a European descended population and forgot to check it in others. So this is very humbling to us. And it makes us think that if we really, really are going to be precise, we have to probably make sure that everything we're doing is very real and trustable. So I'll finish my comments by saying the future isn't just happening to us. We have to build it, and that's what we've concluded at the AHA, that we have to steer our ship and we have to chart our course. And I would say that as a challenge to us in the cardiogenic shock field. It's fun to do debates and stuff, but what we really need to be doing is saying, what are we going to do from here? And I think it's important to go back and say, what are the other big scourges in our country? What have we done? So none of you remember rheumatic heart disease. It was the largest killer in the 1920s when the American Heart Association was beginning. It was the leading cause of death in young people, and in the next age group, only secondary to tuberculosis. First, they decided, listen, we got to get organized, we've got to establish the Jones criteria. And then they tried this newfangled drug called penicillin. They did it very carefully, and you know, the rest, you know the story. I, old as I am, have never seen acute rheumatic fever. That's how successful that was. Acute myocardial infarction, we've talked about it. Thrombolysis began early in 1970s, but I remember seeing as a fellow pictures at a big late-breaking trial of TPA being given in an acute MI, and you watch the clot go down the artery, and everybody, you know, thousands and thousands of people went, and it was so exciting. And then what happened, and that was because people didn't believe that myocardial infarctions were caused by spasm, which is what everybody believed. First it was clots, and then they said, no, it was spasm. And they came back and said, no, I really think it's clots. Let's try to get rid of them. And so there was large clinical trials with strict definitions, TIMI scores, there were standardizations, there were careful trials, little at a time, you know the rest. And then acute stroke, which is probably the most exciting story. The TPA was not given in stroke till about 1996. Endovascular thrombectomy was not till 2018, where there were 5 trials presented at the International Stroke. And then the key to that was new imaging techniques. So we need to learn from that. In addition, very quickly thereafter, there were clinical practice guidelines that were written about what was known and the evidence supporting that, and the evidence-based practice implementation was given, and that's the key, and that's what we need to do now. So I believe strongly what Dr. Deming said, uncontrolled variation is the enemy of quality, and that's what we're doing in cardiogenic shock. We have uncontrolled variation. Everybody's doing everything. And so the first step is what we've heard just in the last speaker, which was developing standards for cardiogenic shock, and we have the SCI classification, and that's the first step. And so what we at the American Heart, and this is a little bit of the paid political announcement, is we decided that we needed to address things by developing a registry. And I'm running out of time, but I do want to tell you why we're trying to do this. This is not to say other registries don't do a good job. They're doing a terrific job. In fact, they're doing so great that we reached out to every registry in this country and said, join us. Keep your registry doing all the good stuff it's doing, but join us, put your data in, and most people have done that. We want to characterize the epidemiology. We want to provide evidence driving best practice. What is the good way to do things? We want to produce regulatory and clinical research infrastructure. We intend to do randomized trials, so-called platform trials, off this registry, so it's a hybrid, like cars. We're doing hybrid between a registry and a clinical trial. Industry has been at the big people table all along. Most of the time industry is put at the kids table. They're at the big table, and they said, we need data to continue sending to the FDA. And as I said, we want to do metrics. And finally, we want to strive for health equity. So in my last few, and I want to acknowledge some of the key people. This would not be anywhere if it wasn't to the tireless work of Dave Morrow and Bukoff, who are our PIs. There are many other people you see here. There were all kinds of people that we've asked to help us, including heart failure docs, critical care docs, cardiac surgery, invasive, pump techs and nurses, industry experts. The FDA has been very, very supportive of this. CMS has been a very important provider to help us, and then the staff. And we started with this paper that came out of the SHARC Consortium saying, here's the standardized way we're going to call this. And then we went to every other registry and said, show us your case report forms. We'll walk it all to make one common database, one common definition, so that as we go forward, we'll be able to not only utilize data from other registries, but we'll all know what we're talking about when we do the clinical trials. We've done an amazing job, I think, but I'm biased, over a very short period of time, really about a year and a half. We're currently we currently have over 4,000 patients enrolled, and all over the country. And what we're doing is we're paying hospitals in rural areas or in traditionally under-resourced areas who say, we just can't afford to do this, because everybody else is doing this for free, by the way. It's the going rate at the American Heart. We pay you zero. But we do pay for technical things at rural hospitals and in small hospitals at under-resourced areas, because we don't want to know just what's going on at the hub. We want to know what's going on in the spokes. And I'll show you just one slide that's very encouraging to us, and that is about 20% of our patients collected thus far are African American. We have about 11% Hispanic, and we expect to get larger in that group. And these are groups that are traditionally not well represented in other registries. I've run out of time, and I want to be respectful of it. I will finish with this, this picture that came out of a paper that we all wrote about looking back at the science, not just from the American Heart, but the science you all and we all have participated in the 100 years. It's a really fun read if you haven't read it, just to look at the things if you're a history buff. And there's some really important things along our course that I think really resonate for the cardiogenic shock community as well, is to really embrace new technologies, but also to embrace a diverse investigator population, a diverse clinical population, and a diverse patient population. To really think about systems of care and quality improvement are as fundamental. My bias is that we've been very device-centric in cardiogenic shock. We've heard some really nice talks today about new therapies. Maybe we need to start with some drugs, for example, in some of these patients. So I really, again, appreciate the opportunity to talk a little bit about our future, and I wish you well in what you're going to do. I think I'm very bullish on what we can accomplish in cardiogenic shock, but we need to speak with a voice that is knowledgeable about the classification, and we need to speak with a voice of diversity, and we need to speak with a voice of hope. So thank you very much.